Hello everyone. I am going through the slideshow for chest anatomy and positioning for RADT 50. First we need to talk about the thoracic cavity, which is our primary area of interest on the chest x-ray. This space has the lungs and the heart, a bunch of accessory organs and glands, and chambers that we deal with. The pericardial cavity and the right and left pleural cavities where the lungs reside. Space between the lungs is referred to as the mediastinum. This contains all the thoracic structures except for the lungs and the lining of the lungs called the pleura. This is a cutaway of the thoracic cavity. Just removing the anterior ribs, you can see the right and left lungs, and nestled in between them, the heart. The thoracic cavity is bordered on the inferior surface by the diaphragm, the muscle that separates the chest cavity and the abdominal cavity. The trachea is of interest on the chest x-ray. This is your windpipe. It's a fibrous muscular tube with C-shaped cartilaginous rings in its walls that keeps the airway open. These rings of cartilage so that your windpipe does not collapse. The trachea is in the midline and it sits anterior to the esophagus, so it is the more forward portion of your throat. Unlike the trachea, the esophagus does not have cartilage propping it open. So when there's nothing in your esophagus, when you're not swallowing food or liquid, that esophagus is flat and therefore nearly impossible to see on a regular x-ray unless there's air or food or liquid inside it. And in fact, when we need to see the esophagus for an exam, we have to use some type of contrast media such as barium or iodine that will absorb a lot of x-rays and show it on our picture. Otherwise, you typically do not see the esophagus if nothing's in it. Anatomy that you should know with regard to the trachea is the carina. This is a hook-like process on the final cartilage of the trachea. And this is the dividing point. The trachea bifurcates at the carina into right and left primary bronchi. Each primary bronchus enters the corresponding lung. The left primary bronchus, also known as the left main stem bronchus, is more horizontal. This is because the heart is there. So it's going to sit at a more horizontal angle because of the heart. The right primary bronchus is shorter and wider and more vertical than the left primary bronchus. Its position and size make it easier for foreign bodies to enter the right bronchus. What this means is if you aspirate something, take it into your airway, it is more likely to lodge in the right primary bronchus than left because the left is horizontal. It's a steeper angle on the right side. So it's going to drop into that vertical shaft rather than the more horizontal. Lungs are vaguely triangular in shape, so they use triangular terms from geometry in grade school. The superior portion of the lung is called the apex. This part of the lung extends above the clavicles on the chest x-ray. The inferior portion is known as the base. This rests on the diaphragm, and it extends farther in the back and the sides than it is in the front. So it's not like your diaphragm is just a flat drum head. It actually drops in the posterior portion. So there are parts of the lungs that you will not see on your typical posterior-anterior projection. We need a lateral view of the lungs to see all of the lung cavity that extends on the posterior side of the diaphragm. Another crucial point for chest x-ray is known as the costophrenic angles. We'll see images, and I will point these out for you. Costo means rib, phrenic refers to the diaphragm. So this is the point at which ribs and diaphragm meet. You will notice a sharp point on a chest x-ray where the lung border is. This is required for your chest radiographs. If you do not have both costophrenic angles visible, you must repeat the image. There's also the medial border of the lung. This is the part where the bronchi enter the lungs, is known as the hilum. Visually, on your image, the right lung is shorter than the left because you have the liver taking up space on the right side. The lungs are in constant motion whenever you're breathing. The diaphragm moves as well. So the lungs move inferiorly during inspiration. When you take a deep breath, the diaphragm descends, the lungs fill with air, and the lungs and diaphragm move superiorly during expiration. When you're exhaling, diaphragm rises, lungs sort of rise upward. Each lung is enclosed in a double-walled membrane called the pleura, 2 layers. You may remember this from anatomy and physiology. The visceral pleura is attached to the lung tissue itself. The outer layer, the parietal pleura, essentially lines the chest wall. These 2 membranes have a small amount of fluid in between them to act as lubricant because they slide on each other. So imagine that you have 2 pieces of plastic wrap. You put a little bit of oil on those and slide your hands. They're going to move on top of each other. Each lung has lobes. Right has 3, left has 2. Again, because of the heart. Left only has 2 lobes. Within the mediastinum, this is a space formed by the sternum, the spine, and the lungs. Everything boxed in there. We have heart, the great blood vessels, the trachea, the esophagus, the thymus gland, part of the lymphatic system, plenty of nerves, fibrous tissue, and fat. Let's look at some chest x-rays now. These are labeled for anatomy that is visible, and you do not need to know all of this for this course. Just pointing out where structures lie. The manubrium is the most superior segment of the sternum. You can see the right and left clavicles over here. Apex of the lung, base of the lung. This is pointing out great vessels, heart, and lung fissures. Note this sharp point here and here. These are your costophrenic angles, right and left. Down here, gastric bubble. This is air in your stomach. There's always going to be air in your stomach, and you're going to see it rise up when your patient is standing upright. That is the gastric bubble. Get used to looking at x-rays from this perspective. Now, we take chest x-rays with the patient facing our wall stand. So if you were facing the wall or facing like a closet door, x-rays enter from the back, exit the front. But that's not how we display them for the radiologist to read or on our monitors when we are reviewing our work. We present x-rays, we display them as if you were looking at your patient face to face. So your patient's left side is over here, as if you were looking at your patient directly. So this image is flipped from how it was acquired. Apologize for the low resolution of this image, but it does point out the airway nicely and illustrates where the clavicles are, your ribs, trachea highlighted behind the sternum here. Note the carina, the bifurcation point between left main bronchus or left primary bronchus and the right primary bronchus. In terms of acceptability for an image, this would be insufficient because the costophrenic angles are clipped on both sides. You can count ribs on x-rays. In fact, you need to. You have 12 ribs, left and right. You can number them. Essentially, you're going to be looking for the first rib, which in this 2D representation of 3D anatomy, the first rib curls around in the front. So here is the left first rib, and so on. Another low resolution image with a bunch of anatomy. On the sides, I have spelled out what all of these abbreviations mean. You don't need to know the abbreviations. Just pointing out some of these that are important for us. Right clavicle highlighted completely here. So left clavicle is over here. Collarbone. Trachea. The thoracic vertebrae behind the trachea. The carina. So we have the left primary bronchus, right primary bronchus, right pulmonary artery, right heart border. Costophrenic angle is here. Does not mean certified public accountant in this case. Right hemidiaphragm and breast shadow. So the liver is under the right lung. And on the left-hand side, we have the gastric air in the stomach. So the stomach is on the left side, liver is on the right. Here you are seeing air in the colon. The ribs are numbered on the left-hand side. And more heart anatomy is over here. The aortic knob or knuckle. The aorta, primary artery in the body, comes off the left ventricle and then arches away. So you see a knob on the left-hand side. So just to review, which lung has 3 lobes? That is the right lung, because the left only has 2, thanks to the heart's presence. And aspirated foreign objects are more likely to lodge in the right primary bronchus. The position of the heart makes the left primary bronchus just a tiny bit more horizontal than the right. So objects coming down the trachea have an easier time ending up in the right primary bronchus. Now we're going to get into general procedures for taking a chest x-ray. One of the main things you will do in the program is develop a routine for introducing yourself and confirming that you have the correct patient and the correct exam. This is crucial. This is not a script that you have to follow word for word, but you do have to convey certain pieces of information. When you are going to be interacting with a patient in the exam room, you're going to introduce yourself. And it is a requirement that you identify yourself as a student radiographer. So in this case, hello, my name is blank. I'm a student radiographer who will be taking your x-rays today. It looks like your doctor ordered a chest x-ray. Is that correct? So here, you are introducing yourself, identifying yourself as a student, and also verifying the order. Sometimes orders are incorrect. Sometimes something goes wrong and you have the wrong patient. This is a chance to correct the error before something bad happens. So if you have a chest x-ray, you can confirm that with your patient. If you have an extremity, such as an elbow, what I recommend is not saying to your patient, we're going to x-ray your right elbow. You're going to say something along the lines of, I have an order to x-ray your elbow. Which one is injured? That way the patient will tell you, and you can match that with the order. And if it's incorrect, you'll catch it before you x-ray the wrong side. Next, we're going to confirm your patient's identity. All patients getting x-rays have a wristband with their name, a date of birth, usually some sort of medical identifying number. This is a requirement from the Joint Commission. So we are going to confirm that we have the correct patient. So we are going to check the patient's wristband. And I strongly recommend that you have your patient tell them your name, first and last. Tell them their name, excuse me. And their date of birth. In this case, see your wristband, please tell me your first and last name and your date of birth. You don't want to be looking at your order and just read your patient's name to them. You want them to read it to you and confirm against your order that it is the correct patient. In class, we don't have wristbands, we just simulate. Take a look at your wristband, you hold your wrist out, you ask them to tell them your name and date of birth. For female patients, we have to ask if there's any chance you could be pregnant. So female patients of reproductive age, this varies from site to site. Some hospitals have different age ranges than others. But get used to asking this question. Any female patient of childbearing age, you're going to ask if there's any chance they could be pregnant. This means you're going to be asking 12-year-old girls if there's a chance you could be pregnant. Just get used to it. Patient preparation. We're going to remove artifacts that could interfere with viewing the anatomy of interest. This includes objects such as earrings that hang down below the shoulder, necklaces, jewelry such as nipple piercings, hair ties. Wet hair will show up on an x-ray because it's denser than dry hair. It will absorb more x-rays. So we need to put that up with a hair tie. Clothing artifacts such as bra straps, clips, tight elastic, metal buttons on shirts. Just remove it all. T-shirts would be typically okay unless they have glitter or thick embossment on them. Generally, for a chest x-ray, you're going to have your patient remove everything from the waist up and put on a gown, ties in the back. Get in the habit of specifying articles of clothing that you want removed. So specify everything from the waist up, your shirt, your bra, because you will have patients that take shirt off, put on a gown, leave the bra on. You don't see that until you take the x-ray and you notice the clips over part of the anatomy, and then you have to reshoot it. You are doubling the patient's radiation dose because of the artifact. Distance. Upright chest radiography uses a 6-foot distance, so 6 feet between the x-ray tube and the image receptor. This minimizes magnification of the heart. And it also improves the recorded detail. So the edges of every object on the X-ray appear sharper the more distance that you have. So chest X-ray standardized at 72 inches. Left or right side markers must be included on each image. This is a legal requirement. As I mentioned before, we flip chest X-rays visually before we send them to the doctors. It's not the way that we shoot them. So any X-ray is reversible, and there can be no indication of whether you're looking at the left or right side unless you have a lead marker visible on the picture. Radiation protection, we're going to shield all patients. Most facilities have a movable shield that's on wheels that can just be rolled behind your patient, or clip-on lead shields that hang on the waist, just belt around the patient. When possible, you want to explain and demonstrate the positions that you want your patient to stand in. And you are also going to give clear breathing instructions. This is super important for chest X-rays. We make these exposures for chest X-rays after the second deep inspiration. So an example of what you would tell your patient is below. Take a deep breath in. Now blow that air out. Take another deep breath and hold your breath. Don't breathe, don't move. Then you'll make your exposure. Or in the case of a lab, you will make a simulated exposure. Why do we do this for chest X-rays? Well, we want to see as much of the lungs as possible. If you just take a deep breath and hold it, you'll see a good amount of lung. But if you make 2 deep breaths, you will see more lung field. The diaphragm will shift lower. You've essentially primed it to open up a little bit more. So second deep inspiration. You want to be very clear and not rush things. You don't want to say, take a breath, blow it out, take another breath. Let them breathe in and out. But you don't want them breathing while you take the X-ray. So they're going to hold their breath, telling them don't breathe, don't move. If they're holding their breath but moving around, you're going to get a blurry picture. So be very clear in your instructions. We're going to go over primary chest X-ray, the PA chest, so postero-anterior movement of the X-ray photons. They're going to enter the posterior side of your patient and exit the anterior side. So that is a PA projection. We shoot these upright whenever possible because we want to see air fluid levels. So when you're standing upright, air is going to rise, fluid will drop. You will see a distinction if there is fluid in the lung field. Standing upright also allows the diaphragm to move to a lower position. Now, we do obtain these pictures on patients who are seated, either in a wheelchair or a hospital bed or a gurney, or even lying on their back on the table. But whenever possible, we want our patients upright. Not every patient can safely stand, so we have ways of getting around that. We're going to put safety first, but if your patient can stand, if they're not dizzy, we're going to have them upright for a PA chest projection. Our image receptor will use a 14x17 computed radiography cassette, or you may have a direct digital detector that does not use cassettes. We are going to practice in class on campus with cassettes. So we have a 14x17 cassette that will fit nearly every patient for a chest X-ray. Your typical male patient, you're going to have that cassette in a crosswise orientation. So essentially, a long rectangle, sort of like the shape of, let's say, an envelope. So wider than it is tall. Typical female patient, you can place in that same crosswise pattern, or you can put it in the other orientation, which is called lengthwise. So it is taller than it is wider. And we're going to shrink the light field for your average female patient. The amount of light field will vary from patient to patient. You will adjust based on their body type, their body habitus. But you are never going to have light going past the edges of the cassette. The image receptor is there to receive radiation. So if you have radiation going past the margins of the cassette or the detector, then it's just extra radiation dose to your patient because there's nothing to actually receive that image. So it is crucial that the light field, the radiation field, never must exceed the dimensions of the cassette or the detector. Here's how your patient will stand for a PA chest, facing the wall stand, the mid-sagittal plane centered. The patient's weight will be equally distributed on both feet. The top of the image receptor, 1.5 inches to 2 inches above the shoulders. We want the shoulders not hunched up. We want them relaxed in the same transverse plane. You're going to roll the shoulders forward. What we're doing is sliding the scapulae to the edges of the lung field by rolling the shoulders forward. Usually, wall stands have handles around the back that you can have your patient hold on to, or, as demonstrated in this picture, patients can have the backs of their hands on their hips and then roll the shoulders forward. The central ray is the dead center of our X-ray beam. It is a theoretical single X-ray in the exact middle of the X-ray beam that travels straight out. This is essentially just our centering point. Where do we put the exact middle of the beam? Every X-ray projection has a point where the central ray will enter your patient. For a PA chest, it's going to enter the mid-sagittal plane at the level of T7, so the 7th thoracic vertebrae, 7 out of 12. This is typically 7.5 to 8 inches below the easily palpated C7, also known as the vertebra prominens. This is also typically about the span between the thumb and the 5th digit. You may also feel for the inferior portion of the scapula that tends to correspond with T7 in the body. And we're going to make that exposure at the end of the second deep inspiration. This slide is copied from the body planes PowerPoint, but it just shows the key landmark that we use for a chest X-ray is C7, the 7th cervical vertebra. The spinous process projects at the base of the neck. You should be able to find this on your own neck and on your patient's very easily. Just place your finger at the mid-neck and slide it down. You will encounter a bony lump at the base of the neck. This is the spinous process of C7. So how do you go from C7 to T7? Well, you can extend your hand in a sort of shaka, surf projection. So if you put your thumb On patients C7, the span of your hand is about 7 inches. And if you really extend it, then you can get to about 8. You can measure this distance. So thumb on C7, hand extended like so. The bottom of your tip of your pinky going to be pointing at T7. Let's look at some images. This is your typical PA chest. Note the orientation of this image. It is the lengthwise cassette orientation. This is appropriate for someone with longer lungs. So tall, slender patients typically have longer lungs than a more barrel-chested patient. They're going to have shorter but wider lungs. So in this case, the lengthwise orientation is appropriate. We want to have the entire lung field represented from the apices to the costophrenic angles. Here are some positioning criteria. Evidence of proper collimation. This means we can see the borders of the image. Where the X-ray field stops, it should not go past the edges of my cassette or detector. The entire lung field should be visible from the apices to the costophrenic angles. Apices, right and left costophrenic angles. We've achieved that. No rotation, very important. The sternal ends of the clavicles should be equidistant from the vertebral column. If your patient is not rotated, the collarbones and the sternum should all be the same distance apart from each other. Your trachea should be visible in the midline. If your patient is turned, that airway is going to shift. And you should have an equal distance from the vertebral column to the lateral border of the ribs on each side. Sternal ends of the clavicles, about the same amount of space between them and the vertebral column. Trachea in the midline. And the third criteria, the width of the lungs is equidistant. If you're rotated, one side is going to look shorter and the other side will look longer. Here's a subtle but important rotation. You can see there's a gap on the left side where the arrow is pointing. A wider gap between the end of that clavicle and the manubrium of the sternum compared to the right clavicle. So that indicates that this patient has shifted, has turned to the left. We want to see proper shoulder rotation demonstrated by the scapulae projected outside the lung fields. Going back, scapulae on the right side and on the left. Note that the shoulder blades are on the outside margin of the lungs. They're not overlapping here. We're giving the doctors a better look at this portion of the lung, moving the bony anatomy off to the edges. Proper inspiration, demonstrated by 8 to 10 ribs visible above the diaphragm. So you will be counting ribs to evaluate your chest x-rays. We want to see 8 to 10 ribs visible above the diaphragm. Here's an example of inspiration versus expiration. This appears to be the same patient. And sometimes we do both. So they can look for pathology. The ribs are counted here for you. Notice 10 ribs visible above the diaphragm, On this first image, this is inspiration versus expiration. We're pushing air out of the lungs. The diaphragm rises. Notice how compact the lungs appear versus inspiration. You will see this fairly frequently. Even though you give very good breathing instructions to your patient, they may not follow them. So when you are evaluating your image and you have given instructions for inspiration and you end up with something along the lines of this image, you will need to repeat it, because perhaps they didn't follow your instructions very well. You can ask them, did you take a deep breath for that one? No, I didn't. Okay, I need to reshoot this. The diagnostic value is limited if they are not breathing in deeply. Some selected chest pathology, how it looks on images. Pneumothorax. This is a collapsed lung. It can be a complete collapse or a partial collapse. What this involves is air entering the space between the chest wall and the lung. Remember that pleural lining? Essentially, when you are breathing, you have one line of the pleura sliding on top of the other. Ribs are moving, diaphragm is moving, lungs expand to fill with air or exhale and compact. When air gets into that pleural cavity, it disrupts that routine and it can collapse the lung. And so you will see the lung deflated. So medical personnel need to remove that air from the pleural cavity, and then the lung will inflate itself. Air in the abdominal cavity. Air may be visible under the diaphragm. Now note, on this picture, there's a distinction between the air in the abdominal cavity and the air trapped in the stomach. This is another reason to do these exams upright, because air in the abdominal cavity will rise up and be trapped under the diaphragm. This is not good because it indicates a bowel perforation. Your intestinal tract is a closed system. If there's a perforation, air is escaping, you're going to have serious complications and infection as a result. Pleural effusion. This is excess fluid in the space between the visceral and parietal pleura. In this case, pretty obvious on this image, but sometimes the only difference is instead of a sharp costophrenic angle, you see a blunted tip, almost like an eraser or a rounding of it. We're taking the sharp edge off that costophrenic angle. That represents pleural effusion. It is not fluid inside the lung. It's on the outside. Other common pathology, pneumonia, which is an infection of lung tissue, can make the lungs appear cloudy on your image. COPD, such as asthma, and infiltrate, which is sort of the opposite of the pleural effusion. This is fluid or a solid substance inside the lung. So it's infiltrated the lung. Emphysema is a form of COPD. This is a long-term increased volume of air in the lungs. People with emphysema cannot exhale enough, so the lungs are constantly full, and you will see an expansion of the lungs. Tuberculosis is an infection caused by various bacteria, often presents with lesions in the apex. So you had to get a TB test for the X-ray program, and to work in healthcare, you get TB screenings every year. Sometimes you have to get a chest X-ray, and what they're looking for is a lesion, typically in the apex of the lung. Congestive heart failure is another very common pathology. This means the heart is no longer as efficient at moving fluid. So the heart tends to increase in size. You have a fluid buildup around the heart. And that shows up a lot brighter on your X-ray. That's it for this one. I'm going to record a lecture for the abdomen PowerPoint next.